Peace be upon you and God's mercy and blessings. Welcome. Today I'm going to present to you a case that I personally encountered. You won't see it often. It's one of those rare cases, but it's important. And while it's rare, it doesn't mean it never happens. It's just not something you see frequently. But it's essential. You should know about it because I've actually seen even more than that. For example, over every 2 or 3 years, I've seen maybe 5 or 6 cases like this. So that's not a small number. In other words, it's quite possible that any one of us could come across such a case. The episode isn't long, it's not exhausting, and it doesn't have a lot of details, but it carries a valuable lesson that I hope will be useful. Welcome. Let's get straight into the episode without any chit-chat. So, we have a 25-week patient. 25 weeks is very straightforward and very common. He was admitted as a typical case, meaning he was admitted without any significant complications or notable issues because there was nothing wrong. We could talk about what the mother had, but really there was nothing to mention regarding the mother's condition. There were no professional or medical issues concerning the patient. He managed the case according to standard protocols, meaning he followed professional guidelines and then made improvements as needed. There was also a technical aspect, and in terms of professional management, we started him on CPAP, then stabilized him. The oxygen levels were 6 and 8, which were very stable. He was admitted to the NICU, and the NICU provided reciprocal care for about 25 months. I admitted him to the NICU, and the 25 was around 30. He was given surfactant because he was not stable, as we mentioned earlier. LIS, or less invasive surfactant administration, is done in a way similar to the Ensure method. For those who haven't heard about it before, it means we administer the surfactant through a catheter and provide it with breathing support. If you want us to discuss it in more detail, or if anyone wants to see it or wants us to talk about it, we can certainly do that. After that, the patient becomes stable, receives the surfactant, and becomes independent. I will also show you an X-ray in any case. This is the first X-ray before the patient received the surfactant. It's a normal X-ray showing RDS. There is no problem. You can say it's a typical case of RDS. The patient received surfactant, and we did an X-ray afterwards. There was some improvement, and the patient remained in this condition for 4 days. 4 days of RDS on the ventilator with no issues. During these 4 days, trophic feeding was started, and the NL level did not increase. And after that, by the way, his weight was managed well, in case anyone asks about his weight. There was no risk of sepsis. The sepsis workup was negative. First-line antibiotics were started, as well as TPN and trophic feeding. As for cardiac issues, there was nothing, no issues, no murmurs, nothing at all. And they didn't do an echo. There was no problem, just to be clear in this case. So what happened on the 4th day? On day 4 at 25 weeks, he was stable and on 30% FiO2. But on the 4th day, his FiO2 requirements started to increase, and his work of breathing also began to rise. So the important thing is, because he was having some episodes of shallow breathing, they increased the caffeine dose to address the shallow breathing, and then gave a bit more augmental support from 18 to 20 and increased it from 6 to 7. That's the grad. And you could say over a full 24 hours, after that initial observation, as the condition kept steadily increasing, we then performed a comprehensive chest X-ray examination, and it clearly showed this rather strange and unusual appearance. But please tell me, what exactly do you personally think of this particular X-ray image? My work is straightforward, and increases. This is normal if we compare them together, so it is not painful for you. Investigated, written, and written. You will say, she has a shadow in the mediastinum and with her retrocardia, which means that it has neomediastinum. These are the first clear surprises. Think of this as an obstetric complete right lung. This significant opacity can either be a substantial pleural effusion, or it could potentially be a significant pleural effusion, or alternatively, it can be a complete lung collapse. Isn't that right? I mean, these are the main 3. Now, you'll say what makes a difference for you here is the mediastinum. The mediastinum doesn't make a difference for you. From the side of the affected side or the affected side, this is classic talk, if it goes to the other side. It could be an effusion, or it could just be a very subtle change, or a change in the patient for another reason. If there was indeed a noticeable and significant change observed on the affected side, then the underlying issue might simply be a physiological or pathological alteration, or it could potentially be a more complex change if we meticulously re-examine and thoroughly analyze the radiographic images once more. Upon careful re-evaluation, we will invariably discover that there is a distinct blunting or an obtuse obscuring of the normally sharp and acute costophrenic angle, which is a critical anatomical landmark. Furthermore, there will be a discernible accumulation of fluid, known as an effusion, specifically located within the basal area of the lung, often indicative of a pleural fluid collection. This significant effusion exerts considerable pressure, consequently pushing and displacing the entire mediastinum, which encompasses the heart and great vessels, from its central position towards the contralateral side. This displacement occurs in conjunction with and is often exacerbated by a noticeable enlargement or widening of the mediastinum itself, which can be a critical diagnostic indicator. As an experienced X-ray commentator and a practicing radiologist, I will provide you with further intricate details and nuanced observations about these findings so that the overall diagnostic picture becomes entirely comprehensive and unequivocally complete. There could potentially be more extensive evidence of fluid accumulation, or perhaps other subtle pathological processes that warrant further investigation and detailed description. Pneumothorax, so the lung is this triangle here, and the lung is collapsed and everything around it is air. Once the patient was intubated, it was clear that the pressure, let me go into detail here. Once intubated and with good pressure, there was good inflation of the lung, and the good inflation revealed that there was an air leak. It was clear that there was an air leak, but it wasn't very obvious because of the pressure caused by the effusion, the pleural effusion. Once it was well inflated, the X-ray showed that the effusion had gone even after that. Of course, the action in a case like this is to insert a chest tube. When we inserted the chest tube, some fluid came out, a yellowish serous fluid. This means that there really was an effusion. After that, once we recruited the lung, there was an A, so we inserted a chest tube. A classic X-ray. Yes, a beautiful case. The tube is placed on the right side. It covered all the air that was in the pleura, and the lung is now inflated and everything is fine. After that, you have the lines present, the chest tube, the ATT tube, the UEC, and the UVC. We haven't talked about them before, but there was nothing wrong with them. You'll find them slightly elevated, and you have the OGT, and these are all the lines in the last X-ray. Here, a question remains for us. Of course, to anyone looking at the case, it seems normal. What's the problem? It's just a typical sequela. So what's strange about it? Where is it? So the question is, why did this patient deteriorate? But to keep it brief, what happened in the diaphragm? What caused the effusion? And what's the secret behind this? You might say it could just happen normally, without any particular reason sometimes. They did an effusion, and maybe the lung was involved as well. Consolidation means infection, but the lung is well inflated almost. So the consolidation, which is the infection, caused some effusion, and the effusion, after that, when lung recruitment was done, it caused pneumomediastinum and pneumothorax, and there was already some pneumomediastinum, so there were some unrelated issues, okay? But there's something important here. If you carefully examine the X-ray image, let's focus our attention specifically on the X-ray now. You will observe all the distinct lines and intricate details present within it. If you refer back to the initial X-ray taken from the very beginning, you will then be able to accurately reach a comprehensive interpretation. I will meticulously arrange these X-rays, placing them either directly behind each other for a sequential review, or carefully side by side, depending on the specific visual cues and diagnostic requirements I perceive. How can I easily do that in the editing process so that you can see them very close to each other? Maybe that will render things a bit easier for your viewing pleasure. Here, this is the very first instance, right at the beginning, when there was absolutely nothing present, and indeed, there was nothing else to be found or observed. Subsequently, this is the state after we meticulously inserted it, as you can clearly and distinctly perceive. And then the crucial question arises: what exactly did we undertake or accomplish? Furthermore, following that particular action, it was, and this specific outcome, this particular result, ultimately materialized and presented itself in precisely this manner. There isn't a particularly significant or substantial alteration on that specific side or aspect of things, but fortunately there are absolutely no discernible issues or complications whatsoever to report. This in fact represents the very next crucial matter that requires our immediate attention and careful consideration. Indeed, this marks the foundational starting point or the commencement of a new phase of fresh development, or perhaps even a definitive beginning for whatever comes next in our ongoing discussions and evaluations. This is your problem. Lens, home tubes, or GT. It will not cause this problem. It could potentially cause an effusion, but I genuinely don't think that would be the case. This is simply just the delicate balance after it becomes just the delicate balance. An effusion appeared and a pneumothorax also appeared. Look at the UEC, UVC, OGT, and endotracheal tube, all the lines. This is after you place the chest tube, after the lung becomes more inflated, and the drain for the pneumothorax is working fine. But there's one more thing. After a while, maybe the lung became well inflated, and everything looks perfect. After that, we saw the X-ray and followed the clinical course. But there's still something missing. If you look carefully at the line, stop and think for a moment. If you want to think, look at all the X-rays, especially the first two, and the ones after that. You'll notice a change in just one thing, So what is it? Enough suspense? It's the OGT, so the OGT. My friend, the last thing you looked at in the case was actually where the problem was. It was the OGT. It caused a perforation of the esophagus and led to a significant complication. This explains everything. It explains how you could very easily go in on that particular side and diligently do it at first and carefully build the initial comprehensive picture. And then after that, once it had truly started to develop, because of course, in the beginning, I don't want to suffer. You need to know something like this because it was used in that area, the city, but it appears in the city area. If you look at the city area, you'll find that the UGT's position is usually not its normal position. You might be able to tell me, hey, but in the city area, I don't want it to go down because we were looking at the city area. Also, you might say, hey, we tried to insert it and we couldn't, but it was possible. It could be affected by paresthesia because it doesn't want to go down into the project. Every time we try to intervene from above to get it into the 8, it doesn't go in. It was possible for it to be affected by paresthesia in this case, but this gives you a very important point. You need to look at everything in the X-rays, especially the things that seem unimportant. You do X-rays, for example, to see, you need to look at the upper and lower parts, and you also need to look at the front. You might find a difference in the patient, and there are patients like this where there is a difference in the molar or a difference in the molar. You need to see all the details in the patient. This was the experience with the brush. And its treatment is easy and consists of an independent determination, but it must include a determination from the organization. You wait a little while for the perforation to heal, then they try to add the healing to its specific devices to change them, and the healing happens well. But the important thing is to understand what happened in the case and to understand what no one else sees. I hope it was useful, and God willing, we will truly find much better cases for your understanding. Thank you very much.